I'm delighted to invite our next speaker, Dr. Stephen Greenberg. Dr. Greenberg comes to us from Chicago, where he has been practicing anesthesiology and critical care since 2006. But we're also proud to say that he did his critical care training at the Massachusetts General Hospital in 2004, something like that. And we're excited to have him back in Boston. Dr. Greenberg has lectured nationally and internationally on patient safety related to many of the different aspects of patient safety. He serves on about 4 editorial boards for the Anesthesia, as well as several medical journals, and has published extensively in this field. He's also served as the Critical Care Society. He's actually organized several of their meetings and is very active in that arena as well. His publication has been, noted to be one of the best in several of our professional journals, and he was also appointed to be the president of the Anesthesia Patient Safety Foundation. Vice President of the Anesthesia Patient Safety Foundation. Oh, that'll be the next step, though, right? Thank you so much. And today, he's actually going to talk to us about what's important to the Anesthesia Patient Safety Foundation, what is its current focus, and what are some of the future directions. So please join me in welcoming Dr. Greenberg to the podium.
Well, good afternoon, everybody, and I want to thank the organizers for not only inviting me, but our APSF family to this esteemed conference. Before I start, I know I have the arduous task of being the last speaker of the day, so I want everybody just to stand up and stretch really quick, because I feel like I want to make sure the blood still flows before the end of the day. So there we go, good stretch. And that ties into one of the patient safety priorities I'm talking about, which is clinician well-being. So it ties into the talk. So, all right. So we'll get started. The title of my talk is APSF Priorities, something near and dear to my heart. These are my disclosures. I'm the current APSF Vice President and the co-chair of the APSF Patient Safety Priority Groups. I also have the financial disclosures there, none of which I'll be talking about, except for the APSF grant that I received. So what are we going to talk about today? I'm going to talk about this special case of anesthesia for improving mortality. I'm going to identify the increasing problem with safety during and after the COVID pandemic. And I'm also going to identify and discuss the APSF patient safety priorities, and then discuss the education, research, and awareness created by these initiatives. So, the true story of mortality improvement. And based on my literature review, in 1940, anesthesia-related mortality was 1 in every 1,000 patients. And I'm proud to say that today, it's about 1 in 250,000 healthy patients, a near 97% mortality reduction. So you may ask yourself, why such a dramatic improvement in anesthesia patient safety when you look at the rest of medicine? We haven't seen anything near that remark or number. Well, number one, and you'll hear me say this multiple times during this talk, it's all about effective leadership and healthcare organizational safety. So what do I mean by that? That's a buzz term. What I mean is that early on in the 1970s and 80s, anesthesia professionals collaborated with safety scientists to look at accidents in the operating room and then develop safety systems and technologies that indeed improved mortality. We looked at it from a multidisciplinary approach. We also implemented accepted standards on basic monitoring, now called the ASA standards. However, they were actually first implemented at Harvard, called the Harvard Monitoring Standards, by one of my mentors, Dr. Eichhorn. And he found that based on the implementation of the Harvard monitors, there was a 66% reduction in malpractice claims the year after those were implemented. So a dramatic change in mortality and litigation. We also conducted long-term analysis of closed malpractice claims so that we could all learn from each other's mistakes and improve upon them. We were the first to address fatigue of residents serving in-house call, so they get a post-call day off. We created the ASA's Patient Safety and Risk Management Committee, and of course, we created the Anesthesia Patient Safety Foundation in 1985, and among the first specialties to develop medical simulation for training. so that our trainees could see both rare and common events before they actually had to deal with them in real time. So the APSF has been bringing perioperative providers together, again, since 1985. We're made up of 18 board of directors, multi-professional, multidisciplinary group of folks, and we use the APSF newsletter as the education vehicle by which we educate approximately 650,000 of the 850,000 anesthesia professionals worldwide. We now publish this in 9 different languages, but we also are focused on research. And we've given about $15 million in the last 35 years to patient safety scientists. We also have created a top 8 patient safety priorities, which I'll talk about in the next 20 minutes or so. And I'll tell you how we decided on those top 8 as well. So let's go back to 2000. And many of you know this famous report, To Err is Human, by the Institute of Medicine, where they said 98,000 patients die each year based on medical errors. But in that same report, they commented, and I'll quote, "Anesthesia is an area in which very impressive improvements in safety have been made. As more and more attention has been focused on understanding the factors that contribute to error and on the design of safer systems, preventable mishaps have declined." So we all were ahead of that curve, even in 2000. Fast forward to 2019. This is a book by Weirs and Sutcliffe entitled Still Not Safe, and highly recommend you read it. It's a very dark picture of the patient safety movement in the last 40 years, for the exception of Chapter 4, Special Case of Anesthesia. Anesthesiology is the one area of healthcare generally acknowledged to have achieved order of magnitude improvement in safety, so any account of evolution of patient safety must explain why safety in anesthesia improved while it did not in the rest of healthcare. So let's fast forward to COVID and a little bit after COVID. Safety is still a problem in medicine. And in 2022, the World Health Organization published this report entitled Implications of the COVID-19 Pandemic for Patient Safety. And in it, they suggested that central line-associated bloodstream infections went up 60%, MRSA infections went up 44%, and catheter-associated urinary tract infections went up 43%. But they didn't stop there. They said that healthcare-associated injuries, such as falls out of bed and medication errors that Dr. Rebel talked about, went up astronomically high both during and after the pandemic. And they basically said that it's due to short staffing and unsafe systems in healthcare today. Again, in 2023, many of you probably have read this article by Bates, but it was based on 11 Massachusetts hospitals, 2,800 admissions, and what they found was that there was one adverse event in 23% of cases. 22% of cases were totally deemed preventable, and 32% of them were serious preventable events. Again, this is just happening a year and a half ago, so we have our work cut out for us. So how does the APSF tackle this? How are we going to address this as an organization? Back in 2018, we convened our multidisciplinary, multi-professional board of directors, and we used a modified Delphi technique to compare one safety idea to the next. And these top 8, we actually consolidated 2 or 3 of them because of our scarcity of financial and human resources, floated to the top so that all of our human and financial resources really focused on these groups. And I'll name them: culture safety, teamwork, clinician safety, clinical deterioration, Neuro, which you heard a great talk a few minutes ago from Dr. Methencool, perioperative brain health, which the ASA has primarily tackled in their initiatives, opioid-related harm, medication safety, which Dr. Bella talked about, infectious disease, and airway management. So I'm going to touch in the next 15 minutes or so on some of these priorities that we've addressed. First, culture of safety. When we talk about that, we talk about inclusion and diversity. The APSF has addressed this in ASA annual workshops, newsletter articles, the Ellison Pierce lecture at the ASA by Dr. Cooper, and we've also supported a research grant on this topic. But many of us who are anesthesia professionals today, unfortunately, have experienced the 6 categories of disrespectful behavior: passive disrespect for people and rules, passive-aggressive behavior, demeaning and humiliating treatment of non-physician providers, disruptive behavior, dismissive treatment of patients, and generalized indifference of the system. Well, we now know that these behaviors are directly correlated to patient outcomes. And in fact, in 2019, Cooper and colleagues looked at about 14,000 patients in the NSQIP database. What they found is that preoperatively, when surgeons had 1 to 3 complaints from their coworkers, those patients that they took care of had a 14% increase in complications at 30 days. So this actually matters. In Dr. Cooper's critically acclaimed article, I highly suggest you read it, Critical Role of the Surgeon Anesthesiologist Relationship to Patient Safety, he concluded by saying, let's be friendlier to one another. Let's take a surgeon to lunch or dinner, form a focus group, listen more than talk. One of my mentors always told me, there's a reason, Steve, why we're born with 2 ears and 1 mouth. Listen more than talk. Assume the best intentions. Get rid of the stereotypes that we often see and that is rampant in operating rooms. Train together using simulation and read books about communication. Again, fast forward to 2023. In JAMA, this was an article, retrospective, in Ontario, looking at about 10,000 gastrointestinal cancer surgery cases. And what they concluded is that increasing familiarity of the surgeon anesthesiologist dyad was associated with improved patient outcomes. In addition, for each additional time that a unique surgeon anesthesiologist worked together, the odds of 90-day morbidity was decreased by 5%, again suggesting those relationships matter. We think this is such an important topic that we awarded Dr. May Pion-Smith, who is a friend, colleague, board of directors on the APSF, and chief of quality and safety in Boston's Massachusetts General Hospital, $150,000 grant to look at using a qualitative methodology to identify differences in personal relationships between groups and how specialty identities or stereotypes may actually interfere or be helping patient safety working relationships. So the next initiative I want to talk about is teamwork. When we talk about teamwork, we talk about collegial communication and multidisciplinary collaboration. And I'm proud to say that the APSF is the collaborating organization and financial supporter of the Multi-Center Handoff Collaborative. So what is that? That's a consortium of over 16 hospitals of experts that look at handover care, education, research, and awareness, and enhancing all 3 of those focus groups. In 2017, we had our APSF annual Stilton Conference on this topic, and we've had several newsletter articles focused on handover care. We also published this ANA article in 2019 on our consensus recommendations from that Stilton Conference, looking at what handoff elements actually can change behavior at the bedside. What kind of outcomes should we look at? How should we measure what we're doing and instill best practices at the bedside? What research should we invest in looking at handoff success, but what also causes failure at the bedside? How do we look at education and training our trainees to be more facile with this domain? And how are patients and families involved in handover care? Could they actually improve the outcomes that we see when we engage them more at the bedside? And lastly, most of our failures, as everyone knows, is on the implementation side. So really looking at building subject matter experts and figuring out how we can work and develop handovers that work within our system. This is the website of the MHC, and it's really a great tool. They post a lot of evidence-based ideas regarding general handoff tools, ICU to OR, OR to ICU, and they also look at integrating the handoff tool in your electronic medical record, so highly recommend you take a look at that. In 2022, the leaders of the MHC actually developed a very innovative virtual conference that looked at trying to identify the barriers, the facilitators, and then make recommendations. 110 people virtually attended this conference, and over 43 organizations were represented, many of which were non-physician providers. And the recommendations that came out of that meeting were that we need to be more vigilant and look at the risk factors that cause derailment in handover care. We have to have designated locations with minimal distractions. We need to make sure we standardize protocols, but then customize them based on the individual situations. We need automated notifications so that we don't forget that we need to hand over care. And also, we need to make sure that we do more interprofessional training using simulation and other types so that we can get better at this together. The next initiative is clinician safety. Several articles in the newsletter on this topic. We've supported 1 research grant since 2016, and we've had our annual conference on this topic. Now, many of us already know that perioperative professionals, and specifically anesthesia professionals, have a higher than average rate of burnout. And these are some of the causes. I'm not going to go through them. We all experience them potentially on a daily basis, and they're getting worse by yearly and yearly because of all the production pressures we're under. So our Stolting recommendations in 2021, we published in the newsletter, and we're continuing to consider collaborating with national organizations to produce joint statements on the clinician well-being and its importance to healthcare in general. We want to create toolboxes to support the perioperative care team, and they contribute to proactively addressing this problem. We also want to try to develop a financial business case to hospitals that investing in our healthcare professional is the best way to retain folks and to produce safe healthcare. And then we're going to look at more research on terms of the basic science of clinician well-being and how we can advance that to actually, again, develop that argument that is important to invest in all of us. Another initiative is clinical deterioration. We spent a 2019 conference on this, several newsletter articles, sponsored panels, presentations, collaborated with the ASA and other subspecialty organizations to address specific issues related to this topic. We supported prototype developments on this topic and 2 research grants as well. I want to talk a little bit about the feudal cycle, and I think many of us have been there if we're involved in any clinical medicine. And that is where an early career nurse looks at an abnormality at the bedside and says, something's not right. But instead of addressing it, they talk to their senior level nurse, and the nurse calls the intern calls the resident calls the fellow, and finally the fellow might call the attending, and by that time, the patient has had an adverse event. So what we need to do is break through this vicious cycle or hierarchical cycle in medicine. One way we can do this is by implementing early warning systems. And what do I mean by that? There's an afferent limb or an identification limb where we use vital signs, physical exam findings, that then trigger a response, or an efferent limb that helps us to increase monitoring, clinical escalation, and provider notification and rapid response team deployment. But in order to be successful with remote surveillance systems, we need to look at 3 major ideas. One is data. We need to make sure that that data is continuous physiologic data, captured in an electronic medical record, and queryable on a real-time basis. But we also need to make sure that the outcomes are clinically relevant and that there's a high sensitivity and specificity of these tools, and they're performed in real time. And lastly, we need to make sure we manage the number of alarms, because we are all working in an environment where there is alarm fatigue. Most importantly, we also have to appropriately train the responders for the appropriate interventions so that the patients get timeliness and appropriateness of care. So there are several unanswered questions here. Who should respond? How should they respond? Do they reliably increase sensitivity and specificity to clinically meaningful events? And can they improve outcomes by reducing rare adverse events? So in 2019, we convened a multidisciplinary group of experts at our conference to look at failure to rescue. And Karen Domino, one of the leads of the closed claims malpractice database, displayed this data on comparing failure to rescue claims versus high severity claims. And what she reported is that there was a greater proportion of ASA 3 and 4 patients, greater proportion of orthopedic surgery patients versus the other high severity claims. She also suggested that the types of adverse events in failure to rescue included postoperative respiratory depression, CV and respiratory issues related to comorbidities, postoperative hemorrhage, and spinal epidural hematoma. So what we did at this meeting is we broke up into small groups and looking at trying to develop prototypes in the 4 domains: technology, culture, training, and system workflow. So we developed 19 prototypes, and 3 were awarded grants, one of which my group was awarded. So I'm going to talk to you a little bit about what we did. We developed a multi-center trial at Endeavor Health and Mass General Hospital among anesthesia professionals and anesthesia trainees. And we tried to develop an audiovisual decision support system in simulation, looking at amniotic fluid embolism cases and pediatric dental cases. So what we did is we had the intervention group have an earpiece, and when the physiologic vital signs dropped or were abnormal, the voice in the earpiece gave the provider 3 or 4 differential diagnoses that they could choose, And then when they chose that diagnosis, they would get the emergency manual aid to go through the specific interventions. So what we found when we compared to the standard group, which was just the regular clinical decision-making, that the time to diagnosis in the audiovisual tool group was significantly improved in both cases. So our next steps with this is to look at what type of artificial intelligence we might be able to develop, and then what kind of hardware can we develop that's not distracting. So some of what we heard from our providers is that this earpiece was somewhat distracting, and even a Google Glass might be the same. So more to follow on this. In addition to those things that we did, we also developed a 2022 APSF-led perioperative consensus conference on hemodynamic instability. And this is the article that we put together based on that conference. This was a multidisciplinary national conference that was held in Philadelphia. And the recommendations were that we need to create more knowledge as it relates and more transparency as it relates to the harm of hemodynamic stability to patients that we're taking care of. We also need to figure out ways to prevent hemodynamic instability related harm during all phases of care, both pre, intra, and postoperatively. We need to make sure that we develop data-driven quality improvement programs like MPOG, national databases, to figure out how we can not only prevent, but we can diagnose and treat this unwanted problem. We need to inform our patients, make sure that our patients become advocates saying, wait, I don't want this happening to me either in the operating room or beyond. Launch national campaigns and also advance the science in not only continuous monitoring, but preventative measures. We heard a great talk just about a half hour ago on non-operating room anesthesia care, several newsletter articles on this, research grants, and the annual Stelting Conference, so I'm going to skip ahead. Talk a little bit about opioid-related harm. We've had several articles in the newsletter, one research grant, and we do support the ongoing efforts in the United States Congress to promote continuous postoperative monitoring of patients who have received opioids. This is based on the closed claims database, postoperative opioid-induced respiratory depression harm. You see on the left side of the screen there, over 80% of them either die or have permanent brain damage. I think the most interesting thing about this data is that most of the cases are occurring 24 hours after surgery. And if you look closer, 13% are occurring within 2 hours of patients going to the floor, suggesting an opportunity of increased monitoring, but also human resources in that domain. So we spent a whole year in 2019 dedicating education through our newsletter on not only when, but whom should we monitor capabilities for opioid-induced respiratory depression, looking at the Joint Commission guidelines in terms of reducing opioid use in the perioperative period, looking at prescription drug monitoring programs and how we can actually use those to tailor opioid and non-opioid medications throughout the perioperative period, and then using more multimodal analgesia as an approach to reduce these unwanted effects. We heard a great talk about medication safety, so I'm going to gloss over that one. Go to the infectious disease priority. This is APSF's collaboration. We helped develop the 2018 SHAE consensus guidelines on intraoperative infection prevention. We also sponsored state and national panels on this topic, and we made significant contributions to the development and sharing of information related to COVID-19 regarding statements, practice guidelines, and frequently asked questions with the ASA. We also supported 2 research grants on this topic in the last 5 years. So this was that SHAE guidance paper entitled Infection Prevention in the Operating Room Anesthesia Work Area. And again, some highlights: anesthesia care-related infection prevention and policies are really not universal. Most of us know that. Not all anesthesia work areas are cleaned and disinfected between every patient. What if you told the patients that? What would they say? And then we should discourage using multi-dose vials or not using gloves 100% of the time when we're instrumenting airways, and entry into the anesthesia cart, washing your hands both before and after. This was a simulated event by Dr. Bergbach and colleagues showing that the amount of contamination that we have during just one anesthesia case. And you could see all over the place. Some of those were gram-negative bacteria, so not ones that you want to take home with you. This is from the World Health Organization, and again, I'm a big hand washer advocate, particularly being an intensivist. So again, before touching a patient, before cleaning, doing a procedure, after any body fluid exposure, after touching a patient, and then after touching their surroundings. And this is one of our very prolific groups in the APSF, the Infectious Disease Patient Safety Priority Group. Based on the evidence that they have gathered, they do recommend that anesthesia professionals perform hand hygiene at least 8 times per hour during anesthesia care. So I don't know about you, I think I have my work cut out for me. So, next slide. The final safety priority I'm going to talk a little bit about is airway management, something near and dear to everybody's heart in this audience. We've done a lot of newsletter articles, and we've supported 2 research grants on this issue in the last 5 years. I'm just going to mention those 2. In 2018, Dr. Fiaggio developed this randomized trial on first attempt success rate of video laryngoscopy in small infants, found a benefit for VL versus direct laryngoscopy. And then in 2020, Scott Siegel put out this article of identification of difficult to intubate patients from frontal face images using a deep learning or AI model. So they're actually using airways that were easy and difficult and developing a prediction algorithm that might be even better than Malampati and the other scores that we use. So what's the future for our patient safety priority groups? That's the piece bags. So I just want to extend my deepest gratitude to the co-chairs of these individual committees because they work tirelessly to develop strategies to enhance awareness, education, and research surrounding these issues. So again, for culture, safety, teamwork, they're going to develop specific strategies that anesthesia groups can adapt for local practices, which can lead to quality improvement. For clinical deterioration, they're working on developing consensus statements on clinical deterioration in the pediatric population. So stay tuned if you are pediatric anesthesiologists. For Neuro, guidelines for institutional level Neuro advisory boards, and then we just completed production of some ANA articles on the safety of office-based anesthesia that have already been published. For the perioperative brain health, we're going to work with the ASA, looking at best practices for screening tools of delirium and cognitive dysfunction. When you look at opioid-related harm, they're going to create a patient safety video around opioids to engage our patients. Dr. Rabello and Dr. Meyer are working on creating work groups to update 5 medication safety strategies based on our 2024 meeting. The infectious disease group, Dr. Loftus and Charnan, are working on an infographic on the value of hand hygiene in the operating room and decontamination of IV hubs, and then more research on airway management. So what have we learned? How can we transcend from 1.0 to 2.0, now there's a 3.0 is safety? It's really about proactive nature, the just-in-case, not just-in-time approach. And I really believe it's about building and guiding coalitions among your team, but also outside of the team. Engage administration, engage the surgeons and nurses. And once you create that sense of urgency, institute the change, and then measure the outcomes and make sure those outcomes are transparent to the people that are working at the bedside, and modify them. Nothing always works on its first attempt. Make sure that you have a system by which you can look at it and modify it. I think the APSF has done a very good job of spreading educational knowledge. I think the next challenge, or the challenge today, is implementation and sustaining those changes at every bedside in the United States and beyond. We've got to build intrinsic motivation, continue to measure and report things. We got to engage our staff to have energy to make these changes and to continue these changes years and years from now. I want to finish today with extending my deepest gratitude to 3 icons in the field of safety, mentors and leaders, Dr. Ellison C. Pierce, who was the founder of the APSF and the first APSF president, a Bostonian, by the way, Jeffrey Cooper, who is still alive and at MS General Hospital, and very active in our organization, founder of the APSF and past APSF president. Many of you probably know him. And John Eichhorn, also original Bostonian, founded the APSF newsletter, was a mentor of mine, and did indeed inspire folks to develop the ASA standard monitors. So great icons who were founders of our organization. And I'm going to leave you with Ellison Pierce's quote several years ago that's so germane today in practice when we look at patient safety. And that is, patient safety is not a fad. It's not a preoccupation of the past. It's not an objective that's been fulfilled or a reflection of a problem that's been solved. It's an ongoing necessity. It must be sustained by research, training, and daily application in the workplace. Thank you so much, and looking forward to our fireside chat.